1 more minute. I have the participant in already.
Dr. Ong, Dr. Are you ready? I think we can.
Yes, I am.
Start at 3 p.m.
We can start now, Doctor.
Yes.
Okay. Right. Good afternoon, everyone. Welcome to the weekly webinar organized by the College of Physicians Malaysia. We are in the month of rheumatology, and today we are very fortunate to have Dr. Ong Siu Get as chairperson and Dr. Teh Woon Ya as our speaker today for the topic overview and early diagnosis of spondyloarthropathy. Okay, without further ado, I will briefly introduce Dr. Ong. Dr. Ong Siu Get obtained basic degree in MD from National University of Malaysia, then subsequently served as both a medical officer and house officer in University Hospital Kuala Lumpur and also HKL, and subsequently obtained MRCP UK, and further on go to join the rheumatology training as a fellow in both rotating hospital in both Malaysia and in the UK. So she also long time served as a rheumatologist in Hospital Kuala Lumpur and also served before as the head of Department of Medicine in HKL. So without further ado, I will pass over to Dr. Ong.
Yeah, thank you, Dr. Liu. Can you hear me?
Yeah, sure.
Yeah, I'm Dr. Ong. Good afternoon to everyone. I'm the chairperson for today's session, and this webinar is the third of the rheumatology series organized by the College of Physicians of Malaysia. Now, it gives me great pleasure to introduce to you the speaker for today, who is none other than Dr. Teh Woon Ya. Dr. Teh is a consultant rheumatologist currently practicing in Gleneagles Hospital in Kuala Lumpur. Dr. Teh graduated from Malacca Manipal Medical College in 2009 and obtained the MRCP UK in 2016. She went on to pursue subspecialty training in rheumatology and completed training in 2022. She was subsequently posted to Hospital Sultan Ismail in Johor to head the rheumatology unit. Dr. Teh has been very active in the field of rheumatology, having been a speaker for several rheumatology meetings and workshops. She's also active in research, whereby she has produced several poster presentations and publications. Without further ado, let me call upon Dr. Teh to deliver her lecture on an interesting topic, which is overview and early diagnosis of spondyloarthropathy. Dr. Teh, please.
Thank you, Dr. Ong, for the kind introduction. It's my honor to be chaired by Dr. Ong, a very senior consultant rheumatologist. And thank you, the College of Physicians, for giving me the opportunity to share on spondyloarthropathy. So I will just generally talk about what is spondyloarthropathy and how we can diagnose early and manage the patient in a more holistic way. So this is the learning objective of today's topic. So first of all, we have to, before get into spondyloarthropathy, so we must recognize what is inflammatory back pain. This is the most characteristic part of spondyloarthropathy. And what could be other differential diagnosis of inflammatory back pain, and when and where to refer this group of patients. So my content of the topics will include epidemiology of back pain, especially in Malaysia's perspective, followed by recognizing inflammation back pain by evaluation, go through a few differential diagnoses, and what is the current concept of spondyloarthropathy. Thirdly, I will bring you through the referral pathway and give you a conclusion at the end of my presentations. So what is the landscape of back pain in Malaysia? So back in 2007, there is a community survey to look at the prevalence of back pain in Malaysia. it is known about 12% of prevalence in Malaysia, which is quite similar to the global findings. And we have found that in this study, we found that this is also the second most common symptom for a visit to the general practitioner. And it involves up to 90% of young adults at some point in their life. And with a peak age about 35 to 55 years. And there is no gender inequality. So male and female are equally having this complaint. And this complaint has substantially impact on their lifestyle, quality of life, and work-related disability. So this is the community survey that I mentioned about. So after knee pain, back pain is actually the main rheumatology complaint back then. And we can see this group of patients, actually, they are in the very young and productive age group from the age of 15 up to 45 years with equal gender distribution. And when we look specifically in this race of involve all the males, we can see that the lower back pain consists the most across all the races in this all the men populations, because they should be the young sole breadwinner of the family. So you can see this low back pain has significantly affect their productivity. And looking at the study at the reason for encounter private clinic, this study done in 2014, you can see that this is the fourth most common complaint when patients visit into one of the private clinics. And in the public healthcare as well, it is ranked as the 8th common causes of visit to the public health, other than those chronic non-communicable disease such as hypertension, diabetes, hyperlipidemia, URTI, pregnancy. So what have we done so far about our this common complaint, low back pain issue in Malaysia? So back in 2010, we have this guideline produced by ourselves, Malaysian Low Back Pain Management Guideline. But it just generally provides some management of low back pain and didn't much focus on the chronic inflammatory back pain part. And it has been estimated that of all these 20, every 20 patient complain of back pain actually has a condition called spondyloarthritis. So how to make the management of this group of young patients better is, first of all, we have to recognize among all these back pain patients, who are the one require further evaluation and who are the one actually having inflammatory type of low back pain. So first of all, we have to start with history taking. So you have to pick up those with serious spinal pathology by going through some, if the patient complain of feature, to suggest some systemic involvement or presence of red flags. And as we go along, I will elaborate more on the systemic disease that you need to ask further when you encounter a young woman or man come to your clinic with low back pain symptom. So how do we define chronic back pain? So chronic back pain is defined as a pain persists more than 3 months. And it is important to differentiate between mechanical type of back pain versus inflammatory back pain. Inflammatory back pain is a pain localized over the axial and also the sacroiliac joints, which is characterized by these 3 diseases: ankylosing spondylitis, non-radiographic SPA, and so on. And I will elaborate more on the next few slides. So for mechanical back pain, then you could see a long list of diseases over here, which include your degenerative condition and also your disc prolapse, fracture, even infection, malignancy. So you can classify the causes of back pain into these 3 main groups. So the first of all is our main topic today, spondyloarthropathy, they have the characteristic of inflammatory type of back pain, and versus mechanical causes of back pain on the left side of here. And then the other things here, such as infection and malignancy, and also non-vertebral causes such as renal and ureteric stones. So to bring, in order to differentiate this group of spondyloarthropathy, you first have to recognize their back pain characteristic. So for inflammatory back pain, there are a few characteristics that is special, peculiar to them. So usually they are less than 40 years of age versus the mechanical group, which could be of any age group. And inflammatory back pain, their onsets are usually insidious versus the mechanical back pain, which could be abrupt in onset. And the most striking characteristic of back pain, inflammatory type of back pain, is it improves actually with exercise, and it contradict with the mechanical back pain, which often make worse with exercise, and usually they are very much better with rest. And inflammatory back pain, they don't find any relief with rest. And most importantly, in the history, you also have to take symptoms of this morning stiffness significantly more than 30 minutes. In mechanical back pain, you don't see this symptom. And this back pain usually cause night awakening, usually the second part of the night. And sometimes they also having this buttock pain. So this red flag on the right lower corner is important for you to rub the very urgent cases need urgent attention, such as malignancy and TB. So the red flags here, you need to go through with them, are prolonged fever, progressive weight loss, night sweats, a prolonged cough, and any focal neurological sign and symptom. So according to this group of experts, the ASAS group, Assessment of Spondyloarthritis International Society experts, so they have provided a few criteria so that to ease the people to recognize inflammatory back pain. So first of all, your patient has to have this back pain more than 3 months. And the 4 out of the 5 criteria here, you must fulfill 4. So they are usually less than 40 years of age, insidious onset, improve with exercise, no improvement with rest, and there is a night awakening here. So after you have taken your history, then you have to do some physical assessment to identify any serious spinal pathology which require urgent attention. If the person has any red flag symptom. So if none, then you have to look for any other systemic disease which could be present in spondyloarthritis, such as psoriasis vulgaris, any evidence of peripheral arthritis, tendinitis, and uveitis. Yeah, so not to have to stress again, you have to roll out these red flags and get them to have immediate attention. And up to now, I couldn't stress more enough the importance of recognizing inflammatory back pain is because these are young group of patients. If we have diminished mobility, they will significantly affect their productivity and a burden on the healthcare system. So now talking about more into what is actually spondyloarthropathy. It's actually a big class of diseases, and some are more characterized but mainly a spine manifestation. So we call them axial manifestation, and some have more peripheral manifestation such as arthritis and dactylitis. So there are a considerable overlap between the two as well. So we'll go further and talk about more on each manifestation. So in this graphic presentation, then you can see axial actually classified into radiographic and non-radiographic axial spondyloarthritis. So radiographic, if there is already X-ray changes that you can recognize. Non-radiographic is for those have no X-ray changes yet. And peripheral spondyloarthritis are more those with more peripheral signs. And there is a considerable overlap, and the spectrum consists of reactive arthritis, IBD-related arthritis, psoriatic arthritis, and undifferentiated spondyloarthritis, and arthritis associated with uveitis, and even a JIA group of spondyloarthritis. So easily to recognize this one is more of axial SPA or peripheral SPA. So like I mentioned before, if axial SPA, they have more spine or the axial involvement characterized the well-known disease ankylosing spondylitis. So whereas in peripheral spondyloarthritis, mainly they have more peripheral symptom compared to their axial symptom, such as in the case of psoriatic arthritis, reactive arthritis, and enteropathic arthritis. This group of patients often are being overlooked on their spinal presentation because people only think they only have joint pain on the limbs and only. So as I mentioned, the axial spondyloarthritis is quite characteristic, or ankylosing spondylitis is the characteristic of axial SPA, I would say. So this is the old classification by the New York classification for the diagnosis of ankylosing spondylitis back in 1984. So, so you must have fulfilled a back pain and stiffness for 3 months, and also limitation on lumbar spine, limitation of chest expansion, and you have to have a radiographic sign already. So if you're looking at the current concept, you will see that actually to apply this modified New York criteria, the patient need to have a radiographic changes. So over here, so we may see the end of the spectrum of the disease already. That's why there is this group of patients called the non-radiographic spondyloarthropathy. So this group of patients have back pain, but X-rays are negative, but they did show signs of sacroiliitis on the MRI. So in axils, so with that classification, then we have a problem to recognize the the non-radiographic group of patient, and so that we can treat them early in order to prevent the permanent joint damage to their joint and go into the radiographic stage and causing all irreversible syndesmophyte formation. Okay. So there is already a well-known delay in the diagnosis of ankylosing back then in ankylosing spondylitis. In those days, to make the diagnosis of ankylosing spondylitis, it takes about a gap of up to 9 years. So with those classification criteria, we did diagnose them very late already, by 9 years. They will have a lot of permanent damage and deformity. So yeah, this is another view, another pictorial to depict what is called the non-radiographic stage and radiographic stage of spondyloarthropathy. So if you already have X-ray changes, you already classify as ankylosing spondylitis. And this is if in the non-radiographic stage, you need an MRI to prove the sacroiliitis because their X-rays are negative. Yeah. So there is a revision of classification for axial and even for peripheral spondyloarthritis in 2019 by the same group, ASAS group. So it's called the ASAS criteria for axial SPA. So to assist in the diagnosis of axial spondyloarthritis, to be eligible for this classification criteria, so you first identify your patients with chronic back pain, and then the age of onset is less than 45. So some guidelines say 40, some say 45, but they are generally can take into account. So after you have to identify the group with back pain and the age group fits, then you go to look for whether they have sacroiliitis changes or they don't have. So if they don't have these sacroiliitis changes, you try to look for any other spondyloarthritis arthropathy features such as peripheral arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's or colitis, and a previous response to NSAID, a family history for spondyloarthropathy or HLA-B27 positive. So by this classification, revised classification criteria, we have more increased sensitivity to pick up this group of patients rather than waiting until there is a radiographic changes. So we can use other SPA features to support the diagnosis. And for the peripheral spondyloarthritis, according to the ASAS classification, you just have to have peripheral arthritis and any enthesitis or dactylitis, plus one of these SPA features on the left, or you need another 2 SPA features on the right. Also significantly improve your sensitivity to make the diagnosis of peripheral spondyloarthropathy. So we talk about a lot of spondyloarthropathy features. So I would like to go through in more detail with you what are the SPA features over here and here. So inflammatory back pain, we have gone through already. What are their characteristics from the history? And then in the history also, you can ask whether there is a previous response to NSAID, and then after a while, they stop the NSAIDs already. And in the clinical examination, try to look for any evidence of asymmetrical or mono arthritis or oligoarthritis. Enthesitis, sometimes they can have this Achilles tendinitis or plantar fasciitis. Dactylitis is characterized by the whole finger being swollen and inflamed. And also, if sometimes we encounter referral from the ophthalmology team when they present firstly with anterior uveitis, and look hard for any cutaneous signs of psoriasis or even new psoriasis. And if the patient has any symptom of colitis or previously diagnosed with Crohn's or ulcerative colitis, a preceding infection also can assist in the diagnosis of spondyloarthropathy. Some study has proven that Salmonella Escherichia previous recent Salmonella Escherichia infection could sometimes trigger this spondyloarthritis. So on the blood test, what you can look for actually quite limited. So up to 40% of them only have elevated CRP, but a negative, so 60% are negative tests, but this does not rule out spondyloarthropathy. So if you are fortunate, you can do a genetic test, the HLA test B27. So it's positive up to 95% of them. So compared to the general population, so the false positive rate is quite low. So then if you can, in your setting, you can perform imaging, X-ray would be normally sufficient. So you look at the SI, specifically on the sacroiliac joint here, and look for any features or inflammation such as here, loss of joint sacroiliac space, and also erosion here. And we can classify them according to the criteria. So only in the late stage, you see syndesmophyte as such. So this is already 2 years of disease. So in Malaysia also, we have our own data to show that our cases also similarly late to diagnose them up to 9.4 years. Okay. Quite consistent with the international data here. Over here by the ASAS criteria in the UK study by the ASAS group. So 8.6 to 9 years is quite common. So now what is our aim is to identify them early. So their mean age about 20 to, their age range about 20 to 40 lah. And then try to shorten the duration to get to the correct diagnosis. And we want a better outcome for them to preserve their spinal mobility and also prevent all these permanent structural damage, and also have to take account into their socio-economic consequences, involve pain and suffering emotionally, and reduce quality of life. And then to provide them effective treatment now, such as biologic, has now quite available in many centers. So if you are in a primary care or in a smaller district hospital, when should you refer and how should you refer? So like first you have to identify this group of patients, identify the back pain, inflammatory, and then only channel them to the correct place for further evaluations. So even this, the same society, the ASAS society has already come up with this recommendation for early referral for these suspected cases of axial spondyloarthritis. So if your patient has a back pain of more than 3 months and their age of onset is very young, less than 45 years old, with one of the following parameter here is already sufficient for you to make a referral to a rheumatologist. So locally, actually, we also had came up our own referral algorithm adopted from this ASAS questionnaire. So we follow the 3R algorithm. The 3R stand for recognize, review, and then refer. And first of all, you have to identify the red flag symptom and refer urgently for further evaluations. So first, we go through the 3R algorithm. Start with the first R. So this is our Malaysia algorithm guideline here. What is the first R? First R is to recognize. So there are 5 questions here, and then for you to go through. If answer here 4 positive yes, then you really warrant a referral to a rheumatologist. So the first question is age less than 40, and then the onset of pain is gradual onset, and pain improve with exercise, and no improvement when you rest, and there is a pain at night to wake you up from sleep. So this is the first R. The second R is to review. So after you have confirmed on these 5 questions, suspicious or inflammatory type of back pain, you can go through in more detail to look for any physical signs, or even from the history, any specific feature to or spa features. And if your center allow, you may do an X-ray of the involved joint, like such as sacroiliac joint or even the lumbar spine X-ray. And if you can do the blood test, you can proceed with ASR or CRP. But as I say, the positive rate is only 40%. So sometimes if you have a positive history, you really can refer the case already. So like to go through you again, what are the important history when you are clocking a patient with inflammatory back pain. These are all the other symptoms and signs that you need to take into account. And then after you review the rule out the red flags already, which require urgent referral, then you may refer to your nearest center with a rheumatology services in the country. Okay, so I will just briefly touch on the treatment, if at all. Then if at time, then we go through some case discussions. The treatment, I will just mainly touch on what is more accessible to the general practitioner and general physician. So before you, maybe sometime there is a time delay, so you may start the patients on NSAID first to relieve their pain and stiffness, and is also proven to reduce progression of structural damage. When you're giving the NSAID in the correct dose with anti-inflammatory dose in specific. Okay, so but you have to assess your patient's risk, any GI, renal, or cardiac risk before you prescribe NSAIDs. So a good NSAID dose at the inflammatory dose only would be helpful in spondyloarthropathy, not the usual analgesic dose. So you can take note of those anti-inflammatory doses for the common NSAID available in your center. So non-pharmacological also plays an important role. So education on the disease, and then it's important also to do the physiotherapy of the spine, and then modification of their shoe wear if they have tendinitis, and importantly to provide a comorbidity screening to them because they have a high CV disease, hypertension, osteoporosis, depression, along with this disease. So educate them about this, the natural history of disease, and then address their concern and try to maximize their functional status so that they can go to their work, and in the same time also help them to relieve the pain. Okay, and physiotherapy plays an important role to educate them on the correct back postures. So coming to, I'll briefly touch into pharmacological therapy. Here, since it's recently updated in 2022 by the combined ASAS and EULA, the European recommendation. So once you have made the diagnosis of axial SPA, so if there is a pain on the spinal pain, then you may start on NSAID and titrate the dose to assess them after 2 or 4 weeks. At the same time, go along with physiotherapy and educations are important. So before come to a rheumatology center, if there is some waiting time here. So I think this part is more relevant to those who are taking care of rheumatology clinic or helping the rheumatologist. So then you have to further assess whether your patient has more peripheral symptom or axial symptom. So NSAID are not doing so well for those with peripheral symptom. So if the peripheral symptom persists, you may do a local steroid injection or consider sulfasalazine. So for those with pain, mainly axial symptom, after NSAID is recommended to start a biologic treatment. So we have quite a variety of biologic options available now. Okay, then you assess the disease again. So I will not touch more in detail on the biologic part. And then I'll just briefly talk to you about how we assess the disease activity in axial spine. So you started NSAID already. How is your patient's response? So we will do this disease scoring to assess their response. So last time we used to have this style, more of a questionnaire assessments, but in the current management guideline, we is more encouraged to use the ASTAS questionnaire to assess the disease activity. So we want the patient to have below 2.1 and also below, if possible, achieve the remission. Okay, so this is the phase 3 after your patient started biology and how to go about that. So I will not go in detail, but this is how we assess the patient's response, if at all started on biologic treatment. So this is some conclusion from my presentation today. Is nonetheless is to stress on early recognition of inflammatory back pain and make an early referral to your nearest center. These are some of the things you might do before the patient come to the rheumatology clinic. You could do some basic blood tests and also a radio simple X-ray of the involved areas. So all what we want to achieve is we used to have this kind of deformity here, and we don't want our patient in this era ended up in this stage with permanent spine deformity. Okay, so these are few resources that you can refer to, already touched in my presentation. The algorithm referral you can download from the website, and there is also patient education booklet available on the website of Arthritis Foundation of Malaysia. So this is few of the suffering of well-known people. If you know, then Reynolds, this is how he described AS. So AS is truly an invisible disease, and it has taken away the biggest joy in their life. So, and now he already treated and can come back to the stage and perform his singing and pop song. And his dear friend, a model, Harris Hills, share the same disease, and they are passionate to raise awareness about this disease. And some of you may know these are Taiwanese artists who also suffer for ankylosing spondylitis, but he's back on stage and to perform after he is well treated. So awareness need to be addressed so that you still can see these young artists perform in front of you. So I think if I'm not running out of time, I have case to share, but if you have questions to ask, I would love to answer your questions as well.
Yes, Dr. Teh, I'm Dr. Ong here. Can you
Okay.
hear me?
Yes, yes.
Yeah, okay. I think we still have got some time. Maybe we'll go through some of your cases. Is that okay? Because it's only 35 minutes.
Okay,
now.
sure. Can
Or does anyone have any pressing questions?
so
Yeah,
yeah.
why don't we go to the case? I think that would be interesting.
Okay, sure. Let me show the cases. Whether the audience here has encountered a similar case. Okay. So how after the talk, so we want to try to apply all this in your practice. So this is a simple case. A 39 years old man come to your KK for a back pain. So from what I have shared with everyone just now, so you will start the approach by taking a good history. So you would take note of the onset of the pain and the duration of the pain. So whether it's acute or subacute or chronic kind of pain, and to try to localize the site of pain will be helpful. And any aggravating factor and relieving factor, generally just to pick up the SPA feature, so you know they respond to NSAID, and then in the history, if inflammatory kind of pain, it will get better with movement and got worse with rest. And then try to identify other associated symptoms such as peripheral arthritis, any spinal stiffness, and other features of SPA such as uveitis, tendinitis, dactylitis, and importantly, rule out the red flag symptom, which I listed out just now, including the constitutional symptom when you go through the history. So other than that, actually, this is about the current complaint, but importantly, also you have to get the family history as well, whether there is also a family member having this or similar autoimmune disease like psoriasis or IBD. And we know they are associated with high severity, so you go through screening for other non-communicable disease and ask them whether they are taking alcohol or smoking or not, and how is their lifestyle. So this man tell you he is a lorry driver. He need to drive 8 hours a day. So lorry driver, a long haul journeys of 8 hours. So a chronic sitting in the lorry for long will actually trigger the pain. And sometimes they also complain of buttock pain due to the inflammation at the endocytic sites. So after you have gathered enough history, so if you think, then you will go next to physical examination. So you look into the eyes, look for any red eyes to suggest uveitis, skin to look for psoriasis, and even the nail, any psoriatic changes or not. And then clinically, any peripheral arthritis, and then look for their BMI. So BMI, high BMI also confer a poorer prognosis as well. And so in this case, you found a tender and swollen left Achilles tendons, and you find the patients had difficulty in lumbar spine flexions. So if you're in this case, it shows that ESR or 70, CRP normal 5, and that patient complained of neck and low back pain. So you did an X-ray of the cervical spine. So just show loss of cervical lordosis. Over here, we couldn't appreciate any syndesmophyte 5 or any coronal signs. Over the pelvic X-ray, however, we could notice there is already a sacroiliac changes over both sides, actually. So the right side is more, the joint space or loss is more than the left side. So this case illustrates the importance of taking history so that you could recognize inflammatory back pain and do the test accordingly. So this is just a simple case, how you stepwise approach to a patient with back pain. So I'd like to share with you the second case. Also a young man in 20 years old, a single man, come with back pain, work as a clerk, already back pain having 3 years, mainly at night and early morning with stiffness, and couldn't sit for a long time because of back pain in the office, and he has to walk about around the office to relieve the pain. Otherwise, there are nothing much in his medical and family history, and he has been having intermittent use of NSAID for her back pain. So in clinical examinations, okay, he has some reduced lumbar lordosis and lateral flexions, but there's no other abnormality. So just would like to ask the audience, after we have gone through one easy case, what do you think with this history, what would he best diagnose according to the new ASAS classification criteria? Whether this is ankylosing spondylitis, whether it's a non-radiographic axial SPA, or is it too early to decide now? Or you are not sure about what he has. So is there any response you can type in the chat box? Okay, so no one response. So I will just go through in the history here. So there is a young man fit into the symptom already 3 years. This is a chronic type of back pain, and also it has an inflammatory component because it has occurred at night and early morning with stiffness, and the characteristic worse with resting. Okay, and there's evidence of some limitation in spinal movement here. So this patient has a possible diagnosis of axial SPA already, but we are not sure it's radiography or non-radiography until we do the X-ray. So there is an X-ray of his pelvic bone. So there is some changes on the right side here with obscurations of the joint space over the right upper sacroiliac joints on the right side, and there is some raised mildly elevated CRP. So fortunately, this patient has a HLA-B27 turned out to be positive. So this man actually, so the right side is abnormal. So in this setting, if you are sometimes you are uncertain with the changes, sometimes due to bowel shadowing, so it might you will suggest you to proceed with the MRI to look for any features of sacroiliitis. So up to this stage, and with the MRI result available, what would you best diagnose him according to this ASAS classification criteria? So I think it's quite clear cut by now. This is the case of ankylosing spondylitis. So by this criteria, he has this chronic back pain with features of SPA here and with a positive HLA-B27. So he's got a confirmed case of axial spondyloarthritis. So according to the, how would you manage him next? By following the recommendation by ASAS EULA guideline. So of course, sulfasalazine only plays a role if the patient has peripheral arthritis. And NSAIDs, of course, will help with the disease and also halt the progression of the bone erosion. And TNF blockers, of course, there's a role if the patient still has not responded to NSAID. And physical therapy has to be concurrently together with the treatment. Okay, I think this is all I want to share and to put in things into more clinical perspective so that you have an idea how to approach a patient with back pain in your daily practice. So, Dr. Ong, you are muted.
Oh, okay. Thank you, Dr. Teh. Okay, I think we have got a few questions here, right? 3 questions. Number 1 for Dr. Teh. Besides NSAIDs, are there any alternative medications that can be used for patients with AS which who are contraindicated to use NSAIDs, for example, peptic ulcer disease?
Yeah, so actually you can see from the algorithm, so NSAID if really contraindicated, so your patient actually warrant the next course of treatment, which is biologic treatment. Yeah, so far there's no other group of analgesia proven to be effective in spondyloarthritis, and not to say even to halt the disease progression. So at the moment, only NSAIDs works lah. So if really contraindicated, then you have to refer your patient early to see a consult a rheumatologist.
Yes, okay. Thank you. We'll go on to the second question. What kind of physical activities are recommended for patients with ankylosing spondylitis?
So yeah, thank you. Any form of physical activity are encouraged, but in specific stretching type of exercise will be most evidence based for those with axial spondyloarthritis. So like swimming, running should be fine. But if your patients have limitation, just encourage them to do any form of exercise will be sufficient. So there's resources there you can share with your patient as well.
May I just add on? We have to refer the patients to the physiotherapist, and usually we would recommend hydrotherapy to the patients. And please do not go to chiropractors because you have got patients with ankylosing spondylitis. If they undergo chiropractic treatment, and if it is too vigorous, it may result in fractures, because patients with ankylosing spondylitis, they tend to have osteoporosis of the spine, and all these very vigorous exercise may cause some fracture. So you have to be very careful. So referral to physiotherapist is very important.
Yeah, totally agree with Dr. Ong. Yeah.
Next, any role of referring to physiotherapists? I think we've done that. Yes, that's very important.
Yeah, in all stages, even when patient already on treatment, even on biologic treatment, you still have to ask them to continuously go on physical exercise and physiotherapy.
Yeah, because the physiotherapist will give you the best advice, because you cannot do very strenuous exercises in patients with ankylosing spondylitis.
Yeah.
Yeah, with regards to any other questions? Oh, okay, there are some more. How long do we need to follow up and monitor the disease of ankylosing spondylitis?
So it depends on your patient's profile. If already is in a remission state, so we will see them just for maybe 6 monthly screening for this comorbid risk factor. So if they are on biology on treatment, so we have to see them more earlier lah. So yeah, it depends on which phase of disease when the patient come to you. So in primary care, usually we'll ask them to continue with all this NCD screening lah. So for our tertiary center, then normally because we overlook their biologic treatment, or if at all they are on other DMARDs. Anything else, Dr. Ong, want to add on?
No. Yeah, it all depends on the stage of the disease. That is how you determine the interval of follow-up for the patient. Yeah, whether the patient is in remission, in high disease activity, moderate disease activity. That's how we do it. And when we monitor the disease, we usually use the SDS score, besides getting the history again, doing the physical examination, and looking at the inflammatory markers, in particular the C-reactive protein. Yeah. Next, if the patient is with warfarin, what pain relief medication can I give?
Great. So we understand a lot of interaction NSAID with warfarin. So you have to carefully discuss with the patient or perhaps monitor the INR more closely before you really decide the patient cannot it affect the INR so much. Then you have to go to the next option, advanced therapy option already.
Yeah, if NSAID is contraindicated, then of course the biologic would be the next line of treatment. But among all the NSAIDs, so which would you use? There are those that are more favorable, that have got more favorable cardiovascular profile, such as naproxen. So you might probably, for those whom NSAID is not contraindicated, then you can try with naproxen, 500 milligrams BD, and then you try for 2 weeks. If there is no response, you can change to another NSAID. You can try one which has got better cardiovascular profile besides naproxen. Is something that you may consider is celecoxib. So you probably have to go like 200 BD or 400 BD just for a week or two. If there is no response, then you have to go on to biologic therapy. If there is response to NSAIDs, you can continue the NSAIDs maybe for 2 to 4 weeks, reassess the patient. And then after that, if the patient is no longer having a lot of inflammatory back pain, then you can go on NSAID as on demand. Yeah, because there's always a risk of causing peptic ulcer disease, renal impairment, and cardiovascular risk. Are there any more questions for Dr. Tay? I think what is actually very important in patients with back pain is to differentiate whether it is inflammatory or non-inflammatory back pain. That is very important. But sometimes the features of inflammatory back pain, it is not really specific for inflammatory back pain. Some other mechanical back pain also can. Some patients do have inflammatory back pain. They're not, they have mechanical back pain, but they do have symptoms which are like inflammatory back pain. So then, in such cases, besides the history and physical examination, you need to do some basic investigations, such as your CRP, looking to see whether it is acutely inflamed or not, whether the patient, and do an X-ray of the axial spine to look for other causes, such as degenerative causes. It's not uncommon to see patients with degenerative disease, or you may also get fracture. So you need to get a proper history for patients who present to you with back pain. And also to get symptoms like systemic symptoms like weight loss, fatigue, poor appetite. It can go for all these constitutional symptoms, can go for inflammatory, can go for and spondyloarthropathy. It can also go for infection or malignancy. So when you take a history, you need to get a more comprehensive history in order to help you with the diagnosis. But of course, the diagnosis is based on a constellation of symptoms, physical history, physical signs, laboratory tests, and also imaging. And the imaging that we are always mentioning here when the patient has inflammatory back pain is to do the pelvic X-ray, whereby you want to see whether there's any evidence of sacroiliitis. And also sometimes you may need to do X-ray of maybe the whole lumbosacral spine or other parts of the axial spine to give you an idea what pain, what type of axial pain this could be. We do not want to miss conditions. It's not so common to be inflammatory back pain than other causes of mechanical back pain when patients present to you with back pain. Okay, any other comments?
So can I ask Dr. Ong, how do you see the delay in your clinic, the cases SPA being referred, either the clinician cannot pick up the symptom, or the young man or woman always neglected their pain?
I think nowadays we get a lot of cases, referred cases, which actually they always think that it is inflammatory back pain, but in actual fact they are actually not. They're mechanical back pain. Yeah, so we have to rule all this out, rather than thinking that they are all inflammatory back pain. But I had an interesting case recently. A man who is about 48 years old who came with back pain, which is not really on history. It's low back pain, but he doesn't fulfill the inflammatory sort of criteria, but then his CRP is elevated and his HLA-B27 is positive. So he had an X-ray of the pelvis and it did not show any sacroiliitis. But because of the fact, and he was given NSAID, and he had 1 or 2 tablets of NSAID, and the back pain just went away. But because of the fact the patient has got raised CRP and HLA-B27. So I want to watch the patient. Maybe he actually has got non-radiographic axial SPA, but it's just that his back pain is not inflammatory in nature. So I watch him over a time, and my plan is to do an MRI if he get recurrence of the back pain. Sometimes patients do not present with the typical characteristic of inflammatory back pain. Your patients are not like textbook. So we have to look at the whole constellation of science, physical findings, history, and all that before we make a diagnosis, before we can establish a diagnosis of axial SPA.
Yeah. So other than the inflammatory back pain, they can have coexistence of mechanical
Yes,
diseases.
degenerative disease also, yes.
Yeah, sometimes fibromyalgia even also very common secondary fibromyalgia in them. So yeah, it's not a very easy task to like say, okay, according to this assessment, okay, this is in remission sometimes. So we have to sometimes watch them and see how the trend of CRP, and sometimes even we have to do the extent of MRI to see whether really still having inflammation or not, to justify whether to continue this treatment or
Yeah,
whether
and
to
to
change
make
a
the
treatment.
correct diagnosis. Yeah. Yeah, it's not so simple as textbook.
Yeah. So you look the algorithm seems quite easy, easy when, but in our clinic sometimes we have to do a whole lot of assessment actually.
Yeah, that's true. Are there any more questions? Well, I think we have reached 4 p.m. I think time is running out, so we may need to call the session to a close. I shall thank Dr. Tay, but at the same time, I shall let Dr. Liu wrap up the session.
Okay, thank you, Dr. Ong and Dr. Tay for today's session. I think we will just call it today. I will see everyone next week, the last week for the rheumato webinar. Thank you everyone for participating.
Thank
Thank
you.
you very much, Dr. Liu and Dr. Ong. See you,
Thank you.
Dr. Ong.
Okay, bye.
Bye.